Welcome, future medical detectives, to the deep dive. Imagine you've just stepped onto a complex crime scene, and the human body is your most intricate case.
Hmm.
Today, we're sharpening our investigative skills and diving deep into a crucial area that impacts millions: genital tract infections.
A huge topic.
Absolutely. And for a first-year medical student like you, this deep dive is designed to be your shortcut, cutting through the noise, giving you a clear map.
Yeah, and arming you with the essential knowledge you'll need.
Exactly.
Yeah.
To understand, retain, and recall this vital information, all backed by reliable medical sources.
That's right. Our mission today is really to unpack that intricate dance between patient and pathogen, explore how we diagnose these conditions, and grasp the core management principles for a whole range of clinically important reproductive system infections.
And we'll use memorable metaphors, some clever acronyms, and strong anchors to help this information not just stick, but really make sense.
Hopefully make it a bit easier to recall later.
Definitely. And to kick things off, let's establish our first foundational anchor, a challenge for your detective mind. What do you think is the single most important defense mechanism the female body has against vaginal infections?
Ooh, good question.
Keep that question brewing. We'll circle back with the answer a little later in our deep dive.
Sounds good.
So let's start with the basics, our anatomical map. Understanding the layout is like knowing the terrain of our crime scene, right? Crucial for figuring out where infections might take hold.
Absolutely. So in males, we're talking about the urethra, testes, prostate, epididymis.
Right.
Entry points typically involve the urethra or, the external skin.
Okay. And for females?
For females, it's the vulva, vagina, cervix, fallopian tubes, uterus, and ovaries. Here, microbes primarily gain entry through the mucous membranes lining the vagina.
Makes sense.
And both sexes, of course, share the urethra, and then the kidneys are important players further up the tract, too.
Now, let's categorize some key areas as either sterile or non-sterile, essentially, the body's VIP zones.
Yeah, where microbes are strictly controlled versus areas where, let's say, they're allowed to hang out.
Exactly. The VIP lounge versus the lobby.
Precisely. For both men and women, the kidneys are a prime example of a sterile VIP lounge. Absolutely no microbes allowed, ideally.
Okay.
In women, the cervix and all structures superior to it, like the uterus and fallopian tubes, are also considered sterile. Think of the cervix as a vigilant mouncer.
A gatekeeper.
Exactly, maintaining the sterility of the upper female reproductive tract.
But not everywhere is so exclusive, right?
Yeah.
Where does the body actually welcome some microscopic residents?
That's a crucial distinction. In women, the distal, the lower one-third of the urethra and the vagina naturally host a diverse community of normal microbiota. Similarly, in men, the distal urethra can house some skin flora. It's all about a healthy balance.
And speaking of that balance, this brings us to the vagina's acidic army, a truly ingenious defense mechanism centered around lactobacillus species.
Yes. During the reproductive years, the vaginal lining is rich in glycogen, essentially a well-stocked food pantry for these bacteria.
A food pantry, I like that.
And what's truly fascinating here is how lactobacilli use that glycogen. They metabolize it, producing lactic acid. And this maintains a consistently acidic vaginal environment, typically around a pH of, say, 5.0. This low pH actively discourages the growth of most other microorganisms. It acts like a natural chemical barrier.
Which means we can now answer our initial question.
Let's hear it.
The single most important defense mechanism against vaginal infections is the presence of lactobacillus species. They metabolize glycogen, producing lactic acid, and maintain that crucial acidic pH.
Spot on. It's like having a dedicated acid spring defense force constantly at work.
Yeah.
And the clinical implication is huge. If that delicate balance gets disrupted by things like antibiotic use, changes in sexual activity, hormonal shifts, maybe varying estrogen levels, that acidic shield weakens.
Right.
And that significantly increases the risk of infection.
These infections predominantly target the urogenital tract then, encompassing both sexually transmitted and non-sexually transmitted pathogens.
Correct. And because of the close anatomical proximity, the urinary tract often gets caught in the crossfire, as you mentioned.
Now, as budding medical detectives, you need to recognize the red flags, the general signs and symptoms that often scream infection. Many of these overlap, giving us clues to look deeper. We're talking about a burning sensation when urinating, or dysuria.
Yeah, that's a common one. An abnormal discharge, either from the urethra or vagina.
What else might we see?
Beyond those, you might encounter abdominal pain, or even visible signs like blisters, ulcerations, or localized swelling and redness. warm skin sometimes.
Okay.
Other key indicators include a foul odor, pain during intercourse known as dyspareunia,
Catharrhenia.
or frequent urination, frequency.
And the underlying causes can be pretty broad, right?
Yeah.
From sexual transmission to hormonal changes.
Or simply the close proximity of the anus and urethra, which, especially in women, facilitates bacterial spread pretty easily.
All right, let's dive into sexually transmitted infections, or STIs. These are a massive and clinically vital part of this field.
Absolutely. Common risk factors include being under 25, having a partner positive for an STI, a history of previous STIs.
For coexistent STIs, too.
Definitely. Multiple partners, recent change in partner, early age of first sexual intercourse, unprotected sex, so non-barrier contraception, low socioeconomic status, drug use, commercial sex work. These all play a role.
The statistics are quite stark, aren't they?
They really are. In England, in 2024, there were over 360,000 new STI diagnoses.
Wow.
Chlamydia accounted for almost half, 46%. Gonorrhea made up 20%.
Okay.
First episode genital herpes, about 8%. First episode genital warts, 7%. And interestingly, we're seeing a reemergence of syphilis, especially among gay, bisexual, and other men who have sex with men, or GBMSM.
It's quite a dynamic landscape. And on that note, here's another thinking point for you listening. Some STIs are notoriously silent, which common STI is particularly known for being asymptomatic, especially in women.
Think about that one. We'll reveal the answer shortly.
Let's start with a big one, chlamydia, the silent sneak.
And here we go. Here's the answer to our thinking point. Chlamydia trachomatis is indeed the most commonly reported bacterial STI and the silent one we mentioned.
Oh, okay.
Approximately 70% of women and maybe 50% of men show no symptoms at all.
That's huge.
It is. And this bug, it's an obligate intracellular gram-negative bacterium, has this really unique and, frankly, quite insidious life cycle.
Oh, the real genius and danger of chlamydia lies in its two-stage attack anchor, the EBRB cycle.
Yes. Explain that a bit.
Okay, so think of the elementary body, EB, as the stealthy, resilient Trojan horse. It's the infectious form that gets past your body's defenses. It exists outside the host cells.
Right, it's the traveler.
Exactly. But the key insight is how it then transforms inside your cells into the reticulate body, RB. This becomes an invisible replication factory.
The resident that does the multiplying.
Precisely. It replicates within these cytoplasmic inclusions, then reverts back to the EB form to spread. This hidden life cycle is why it so often causes silent infections.
Gives it time to establish and cause significant damage before symptoms ever appear.
Exactly. Clinically, where does it cause problems?
It can infect the urethra in men, the cervix and/or urethra in women, can also infect the conjunctiva, the eye, the rectum, even the nasopharynx.
And the complications
And
can be serious. Right?
Very serious. Untreated chlamydia can lead to pelvic inflammatory disease, PID, in about 16% of cases in women.
Wow.
Which can cause infertility. And as I mentioned, if it infects conjunctival cells, it can even lead to blindness.
Okay, so chlamydia, the silent sneak with that EBRB cycle. Let's turn our attention now to another major player, one you called an agile adversary, gonorrhea.
Yes, Neisseria gonorrhea.
What makes this one such a formidable opponent?
Well, N. gonorrhea, it's a gram-negative diplococcus, so pairs of spheres under the microscope. It's the second most common bacterial STI. Men often present pretty clearly with dysuria, that burning urination, and a purulent, sort of pus-like urethral discharge.
Okay.
Women, however, are frequently asymptomatic, which is a problem for control, though some experience abnormal discharge or dyspareunia, pain during sex.
And you mentioned it targets specific cells.
A crucial point here, yes. N. gonorrhea specifically targets columnar epithelial cells like those lining the urethra and the cervix, but notably not the stratified squamous epithelium of the vagina itself.
Ah, okay. That's key.
That selective targeting is key to understanding its presentation and where it causes infection.
And what's truly fascinating, almost devious, is what we call the gonorrhea gambit, antigenic variation anchor.
Absolutely. This pathogen is an absolute master of disguise. It's constantly altering its surface antigens, the things the immune system recognizes.
How does it do that?
Through several mechanisms. Mutation of individual amino acids, phase variation, which is basically switching genes on and off, and even horizontal exchange of DNA material with other gonococi.
Wow. So it's constantly changing its coat.
Exactly. This incredible antigenic variability is why your body rarely develops lasting, specific immunity. You can get infected again and again.
And that makes treatment harder too, I imagine.
Hugely challenging. It contributes significantly to increasing antibiotic resistance, which is a major public health concern with gonorrhea.
What about spread within the body?
It can attach to sperm, which helps it travel up into the upper reproductive tract, leading to PID in women. And it can even spread systemically through the bloodstream, potentially causing meningitis or endocarditis, though that's rarer.
And for newborns?
Infants born to infected mothers can develop severe eye inflammation, ophthalmia neonatorum, or even blindness if not treated promptly.
Okay, gonorrhea, the agile adversary with its antigenic variation. Let's shift focus now to syphilis, the four-stage serpent, caused by the spirochete bacterium Treponema pallidum.
Ah, yes, the great imitator. This one's a classic for its distinct progression through stages.
And we remember it with the acronym ANCHOR, PSLT.
KSLT, primer, secondary, latent, tertiary. Tell us about primary.
Primary syphilis is characterized by a painless ulcer, called a chancre, right at the site where the bacteria entered the body, often on the genitals, but could be mouth, anus.
And crucially painless, so it's often subtle and easily missed, especially if it's internal.
Exactly. Then, if untreated, it progresses to secondary syphilis. What do we see then?
Here you might see widespread lymphadenopathy, swollen lymph nodes, a characteristic maculopapular rash often on the palms of the hands and soles of the feet, which is quite distinctive.
Okay.
Sometimes accompanied by fever, headache, and things called condylomata lata, which are wart-like lesions in moist areas.
After secondary comes the latent stage.
Correct. This is an asymptomatic period. The person still has syphilis. It's detectable by blood tests, but there are no current clinical features. This can last for years.
And then, potentially, the final act, tertiary syphilis.
Yes, and this occurs years, sometimes decades later. It can involve severe complications affecting the heart, cardiovascular syphilis, or the nervous system, neurosyphilis.
Neurosyphilis sounds particularly bad.
It can be devastating, manifesting as personality changes, impaired memory, dementia, seizures, tremors, even specific pupillary abnormalities like the Argyll-Robertson pupil.
We mentioned recent outbreaks are associated with MSM.
Yes, particularly in that group, but it affects others too. And importantly, syphilis can also be transmitted from mother to child during pregnancy or birth, leading to congenital syphilis, which has very severe consequences for the baby.
So circling back to a previous thinking point, just to lock it in, primary syphilis presents with that painless chancre.
Right.
And secondary syphilis often presents with that widespread maculopapular rash, especially palms and soles. Knowing these is vital.
Absolutely. Okay, moving on. Genital herpes simplex, the recurrent rascal. Caused by herpes simplex virus HSV1 and HSV2. HSV1 also causes cold sores, of course.
And a key point here is transmission can occur even when someone is asymptomatic but shedding the virus.
Makes control very difficult.
What's really characteristic, though, is its recurrent nature. We have the reactivation anchor for this.
Tell us about the triggers.
Well, outbreaks of those painful genital blisters, often preceded by a tingling or burning sensation, are frequently triggered by factors like physical trauma, UV light exposure, other infections like HIV, being immunocompromised, or even psychological stress.
The virus lies dormant in the nerve ganglia and reactivates.
Exactly. Symptoms include those painful crops of blisters, dysuria, redness, sometimes even proctitis if the rectum is involved.
Then there are genital warts, the HPV proliferation. These are generally benign proliferative growths on the skin or mucous membranes.
Most commonly caused by human papillomavirus, HPV genotype 6 and 11. These are considered low-risk HPV types.
Right, low risk in terms of cancer. They're generally asymptomatic, maybe a bit itchy or painful sometimes. Peak prevalence is typically in the early 20s, 2024. Diagnosis is usually clinical, just by looking.
But here's where it gets really important, connecting to cancer prevention with the high-risk HPV, 16 and 18, the cancer conspirator anchor.
Absolutely critical distinction. These genotypes, HPV 16 and 18, are strongly associated with high-risk cervical intraepithelial neoplasia, CIN, and ultimately cervical carcinoma.
And not just cervical cancer.
No, they can also cause oropharyngeal cancers, anal cancers, and penile cancers. This is precisely why cervical screening programs now primarily test for the presence of these high-risk HPV types. Early detection is key.
Okay, let's quickly touch on a few others. Trichomoniasis.
Caused by Trichomonas vaginalis, a protozoan parasite. Interestingly, over 90% are diagnosed in women, but up to 50% of both sexes can be asymptomatic.
Classic presentation.
In women, it's often a frothy, yellow, fishy-smelling vaginal discharge, affects about 20–30%. Vulval itching or pain, dyspareunia. And sometimes, in about 2% of cases, you see this characteristic strawberry cervix on examination due to tiny hemorrhages.
Mycoplasma genitalium.
Yeah.
In gen. You called it the cell wall-less culprit.
Yes, M. genitalium. It's a slow-growing bacterium that lacks a cell wall,
Why is that important?
because it means it cannot be gram-stained. And crucially, it's inherently resistant to beta-lactam antibiotics like penicillin, which targets cell wall synthesis, makes treatment trickier.
And what does it cause?
Commonly associated with urethritis in men and cervicitis in women. It also impacts pregnancy outcomes, increased risk of preterm birth, spontaneous abortion, PID, infertility. It's an emerging concern.
Briefly, Mpox.
Formerly monkeypox, a rare disease caused by the monkeypox virus, a dsDNA virus. Causes small lesions, often hands, mouth, genitals, anus. Most cases are mild, recovery in 2 to 4 weeks, but it gained prominence recently.
And we must always consider the systemic threats, HIV and hepatitis B, C.
Absolutely. HIV, a retrovirus attacking CD4 plus T cells, weakens the immune system, leading to opportunistic infections, primarily an STI, but also transmitted via pregnancy, childbirth, blood.
And hepatitis B and C.
Also transmissible perinatally, sexually, or via needle sharing, can cause liver inflammation, malaise, poor appetite, right upper quadrant pain, jaundice, but often asymptomatic initially. Chronic HBV, especially, can lead to cirrhosis and liver cancer. Screening is vital.
Phew, that's a lot of STIs.
Yeah.
Let's pivot now to non-sexually transmitted infections, non-STIs. Those infections of the genital tract not primarily acquired through sexual contact, although sexual activity can sometimes play a role in disrupting the environment.
Right. A prime example, and incredibly common, is candidiasis, the yeast beast, usually caused by the fungus Candida albicans.
How common are we talking?
Very.
Yeah.
Around 75% of women experience at least one episode in their lifetime.
And what triggers it? Risk factors.
Several things can tip the balance. Antibiotic use is a big one, as it wipes out protective bacteria. Local irritants like SOX, diabetes, HIV infection, using the oral contraceptive pill or HRT, and essentially any shift towards a more alkaline, less acidic vaginal pH.
We had a metaphor for this. Candida is like a squatter.
Exactly. Like a squatter in your home, usually harmless, just hanging out in small numbers. But if the conditions become favorable, say, the pH changes, fewer of those landlord's lactobacilli around it seizes the opportunity and throws a wild party.
Leading to symptoms.
Classic symptoms are vulval or vaginal itching and soreness, a characteristic thick, white, cheese-like vaginal discharge, and sometimes dysuria. Men can get balanitis redness and itching on the penis, foreskin sores, maybe a white discharge.
Okay. Next up, bacterial vaginosis, or BV, the pH party crasher.
Right. Now, this isn't technically an infection by a single pathogen, nor is it an STI, though its prevalence is higher among sexually active women. It's better described as a dysbiosis.
A dysbiosis, meaning an imbalance.
Precisely. An imbalance of the vagina's normal microbial community. It's characterized by an overgrowth of anaerobic bacteria like Gardnerella vaginalis, Prevotella species, and crucially, a significant loss of those protective lactobacilli.
And this affects the pH again.
Yes, the vaginal pH increases, becoming less acidic, typically rises above 4.5. The hallmark symptom is a fishy-smelling, thin, gray, or whitish vaginal discharge. Importantly, there's usually no significant itching or soreness, which helps differentiate it from thrush or trichomoniasis. Under the microscope, you see characteristic clue cells, vaginal epithelial cells studded with bacteria.
Now, for something potentially very serious, toxic shock syndrome, or TSS, the exotoxin emergency.
Yes, this is a potentially life-threatening condition. It's mediated by exotoxins, primarily produced by Staphylococcus aureus, but sometimes group A streptococcus.
What are the risk factors? We often hear about tampons.
Yes, high absorbency tampon use, particularly if left in too long, is a classic risk factor for menstrual TSS, but it can also occur in the postpartum period or related to wound infections.
It is severe, right?
Very. Rapid onset of fever, headache, a diffuse sunburn like skin rash, confusion, vomiting, or diarrhea. It can progress quickly to multi-organ failure. It's a true medical emergency requiring immediate hospitalization and treatment.
Okay. Another important non-STI, especially in pregnancy, is group B streptococcus, GBS, the neonatal nuisance.
Right, Streptococcus agalactiae, or GBS. This bacterium is actually found as part of the normal flora in the reproductive or gastrointestinal tracts of up to 35% of healthy women.
So it's often harmless to the mother.
Generally, yes, but the danger lies in transmission to the newborn during labor and delivery. GBS is a primary cause of neonatal sepsis, blood infection, and meningitis, inflammation of the brain lining, in the first week of life.
Which can be devastating.
Absolutely. It's also associated with premature labor and miscarriage. This is why many places screen pregnant women for GBS carriage, usually around 35, 37 weeks gestation.
And if they are carriers?
The standard practice is to offer intravenous antibiotics, usually penicillin, during labor to significantly reduce the risk of transmission to the baby.
Okay, crucial intervention.
Yeah.
Let's anchor ourselves with an important acronym for infections during pregnancy that can harm the fetus. STORCH, the Congenital Concerns acronym.
STORCH. This is a really useful one to remember. It groups together infections that might cause only mild illness in the mother, but can have serious consequences for the developing fetus if acquired during pregnancy.
Let's break it down. S is for
Syphilis. We've discussed congenital syphilis, toxoplasmosis, a parasitic infection often from cat feces or undercooked meat.
Oh.
Other infections. This is a bit of a catch-all, but important ones include parvovirus B19, causes slap cheek syndrome, varicella zoster virus, VZV, chickenpox, HIV, hepatitis B, rubella, or German measles can cause congenital rubella syndrome, deafness, heart defects, cataracts. Vaccination has made this much rarer in many countries. CMV, cytomegalovirus, a very common virus, often asymptomatic, but can cause hearing loss and developmental problems if contracted in utero. Herpes simplex virus. Neonatal herpes can be very severe.
Okay, STORCH, useful mnemonic. Here's another thinking point then. Beyond the routine HIV, hepatitis B, and syphilis screening in pregnancy, can you recall one of those other infections and storches we just mentioned that can cause specific problems like limb hypoplasia and microcephaly in a fetus?
Think back to the O.
We'll give you a moment.
The answer is varicella, chickenpox. VZV infection during pregnancy, particularly in the first 20 weeks, can lead to congenital varicella syndrome with complications like underdeveloped limbs, hypoplasia, small head size, microcephaly, eye defects like cataracts, and skin scarring.
Right, so VZV under O and STORCH. Good to remember. Let's briefly mention postpartum infection.
Yes, this refers to a bacterial infection of the female reproductive tract following childbirth or miscarriage. Often presents with lower abdominal pain, fever, foul-smelling vaginal discharge. Always need to assess for maternal sepsis in this context.
Okay, let's structure things by site now, looking at infections by site. Targeted troubles, starting with male genital tract infections.
Sure, first, urinary tract infection, UTI. Less common in men than women, generally. Risk factors increase with age, often related to things like catheterization, being over 50, having benign prostatic hyperplasia, BPH, which obstructs urine flow. If it's not an STI, E. coli is still the most common culprit, often from fecal contamination.
Prostatitis, infection of the prostate.
Yes, often presents with UTI symptoms, dysuria, frequency, urgency, but also typically penile or rectal pain, lower back pain, sometimes pain on ejaculation. Examination might reveal a tender, swollen prostate
Urethritis
and inflammation of the urethra. Symptoms include penile irritation or discomfort, urethral discharge, and dysuria. It can be gonococcal, caused by gonorrhea, or non-gonococcal urethritis, NGU. Common causes of NGU include chlamydia, mycoplasma genitalium, ureaplasma urolithicum, and sometimes trichomonas vaginalis. Inflammation of the glands, penis, the tip. Redness, swelling, sometimes discharge or soreness, can be caused by Candida albicans, thrush, but also STIs like chlamydia or even bacteria involved in BV like Gardnerella. Poor hygiene can contribute too.
And epididymoorchitis. That sounds painful.
It is. Infection and inflammation of the epididymis and/or testis. Presents with scrotal pain, swelling, redness, erythema, often fever.
Causes vary.
Yes. In younger sexually active men, chlamydia and gonorrhea are common causes related to high-risk sexual activity. In older men or those who practice anal intercourse or have had urological procedures, gram-negative enteric organisms like E. coli are more common. And don't forget viral causes like mumps virus causing orchitis.
Okay, shifting to female genital tract infections. UTI first, much more common here.
Much more common, largely due to the shorter urethra and its proximity to the anus, making bacterial transfer easier. E. coli is implicated in up to 77% of cases. Risk factors include sexual intercourse, honeymoon cystitis, using spermicides, having a new sexual partner.
Vulvovaginitis, inflammation of the vulva and vagina.
Yes. Symptoms typically include an itchy, sore vagina, maybe abnormal vaginal discharge, sometimes vaginal dryness or pain on urination. Causes are broad, we've discussed many. candidiasis, thrush, trichomoniasis, bacterial vaginosis, BV, but also STIs like gonorrhea or chlamydia can cause associated vaginitis or discharge.
Cervicitis, inflammation of the cervix.
Presents often with cervical discharge, mucopurulent, easy bleeding of the cervix, friability, which might lead to intermenstrual bleeding or postcoital bleeding, maybe dyspareunia. Common infectious causes include chlamydia and gonorrhea, but also HSV and M. genitalium.
And then the big one for female upper tract infection. Pelvic inflammatory disease, PID, the silent scourge of fertility.
Absolutely crucial topic. PID isn't a single infection, but a clinical syndrome. It results from the ascension of microorganisms from the lower genital tract, the cervix and vagina, up into the upper genital tract, the uterus, fallopian tubes, and ovaries.
What bugs are usually responsible?
Most commonly, it's secondary to untreated chlamydia or gonorrhea, but M. genitalium is increasingly recognized. Bacteria associated with BV, like Gardnerella vaginalis, and even enteric pathogens can also be involved, especially after procedures.
Symptoms can be vague, right?
They can be, which is part of the danger. Classic symptoms include lower abdominal pain, maybe unexplained vaginal discharge, irregular bleeding, intermenstrual or postcoital, dyspareunia, dysuria. On examination, key signs are cervical motion tenderness, sometimes called the chandelier sign, because the patient jumps uterine tenderness or adnexal tenderness, pain on palpating the area of the ovary stoops. Fever, nausea, vomiting can occur in more severe cases.
And a crucial diagnostic point when assessing lower abdominal pain in women of reproductive age.
Always, always, always rule out ectopic pregnancy first. It's a potentially life-threatening emergency that can present similarly. A pregnancy test is mandatory.
Consequences of PID.
Severe. The inflammation can cause scarring and adhesions in the fallopian tubes. This significantly increases the risk of future ectopic pregnancy and is a major cause of tubal factor infertility. It can also lead to chronic pelvic pain. PID can cause permanent damage to a woman's reproductive organs. Early diagnosis and treatment are vital.
Okay, now that we know what we're looking for, let's talk diagnosis and management, finding and fixing. These are our detectives' tools.
Right. For lab tests, Nates, nucleic acid amplification tests, are incredibly sensitive and specific. They're the gold standard for detecting the DNA or RNA of organisms like chlamydia, gonorrhea, mycoplasma genitalium, and Trichomonas vaginalis, often done on urine or swab samples.
What about older methods like microscopy?
Still very useful. Microscopy, culture, and sensitivity are important. Microscopy allows direct visualization, like seeing gram-negative diplicaci inside cells for gonorrhea, yeast bucciferae for candida, clue cells for BV, or motile parasites for Trichomonas vaginalis, though Nanette is more sensitive for Trichomonas. Culture is vital for gonorrhea to determine antibiotic sensitivities due to resistance issues. PCR.
PCR, polymerase chain reaction, is another nucleic acid test, often used for detecting viruses like HSV or the monkeypox virus, MPV.
And blood tests. Serology.
Serological testing is key for infections that cause a systemic immune response or have latent phases, like syphilis, HIV, and hepatitis B/C. Detects antibodies or antigens in the blood.
Sample collection depends on the situation.
Absolutely. For men, it might be a penile swab, if lesions present, a urethral swab, first void urine, good for chlamydia, gonorrhea, and AT, or a rectal swab, if relevant. For women, a high vaginal swab, vulvovaginal swab, often self-taken, endocervical swab, or a urine sample or dipstick for UTI screening.
Okay. Management principles specifically for STIs.
Several key things. Generally, referral to a specialized genitourinary medicine, GUM, or sexual health clinic is recommended for comprehensive care.
And crucially, partner notification.
Essential. Partner notification and treatment is vital to prevent reinfection and further spread in the community. It has to be handled sensitively and confidentially.
What else? Testing for other coexistent STIs is standard practice, providing clear advice on safe sex practices, like consistent condom use, and offering support, counseling, and education about the infection.
Let's touch on some key STI treatments, acknowledging guidelines change. Chlamydia.
Currently, doxycycline for 7 days is often first line. Azithromycin used to be common, but resistance is a concern.
Gonorrhea, given the resistance issues.
Treatment is often an intramuscular injection of ceftriaxone, sometimes combined with another antibiotic depending on local resistance patterns. Culture and sensitivity testing is important here.
Trichomonas vaginalis.
Usually treated effectively with metronidazole, an antibiotic that also covers anaerobic bacteria.
Genital herpes.
Antivirals like acyclovir or valaciclovir, famciclovir, are used to manage outbreaks. They shorten duration and severity, but don't cure the latent infection, can be used episodically or as daily suppression therapy. The mainstay for primary, secondary, and early latent syphilis is benzathine penicillin G, given as an intramuscular injection. Later stages, or neurosyphilis, require different penicillin regimens. For tertiary phase, treatment aims more at preventing further damage than eradicating active infection.
MGen, the cell wall-less one.
Treatment is complicated by resistance. Often a course of doxycycline first to reduce bacterial load, followed by azithromycin. Resistance testing is becoming more important.
And management of some other infections, candidiasis.
Usually straightforward with topical antifungal creams or pessaries like clotrimazole or a single oral dose of fluconazole.
Bacterial vaginosis.
Typically metronidazole, oral or vaginal gel, or clindamycin, vaginal cream. Aim is to restore the normal balance.
Group E strep in pregnancy.
As we said, intravenous benzylpenicillin, penicillin G, during labor for known carriers prevents neonatal transmission.
Postpartum infection.
Depends on the suspected source and severity. Often requires broad-spectrum intravenous antibiotics initially, always assessing carefully for signs of sepsis.
Underpinning all this treatment has to be prevention, right? The prevention is key anchor.
Absolutely. Number one is protected sexual intercourse. Consistent and correct use of condoms significantly reduces risk for most STIs. Regular screening, especially for young people or those with risk factors. Vaccination is crucial. HPV vaccine protects against major cancer-causing types and wart-causing types. Hepatitis B vaccine is also routine in many places.
And on a public health level?
Notification and treatment of partners, as we stressed, and contact tracing to identify and treat others who may have been exposed. These are fundamental public health strategies.
Finally, let's wrap up with some special considerations. Beyond the biology, this moves beyond just the pathogen and into the broader human and societal context.
Yes, and some very important points here. First, a critical and sensitive area, anogenital infections in children.
This requires extreme care.
Absolutely. If a child younger than the age of consent, which varies slightly, but generally around 13-16 depending on jurisdiction, presents with a diagnosed STI, or even with unexplained symptoms like dysuria, bleeding, or anogenital discomfort without a clear medical explanation,
You must consider.
you must consider the possibility of sexual abuse. It's a mandatory safeguarding issue.
What's the protocol?
Discussion with a named or designated professional for safeguarding children within your institution or local area is required. There are specific pathways for investigation and support. And just to recall, for instance, under the UK's Sexual Offences Act 2003, any sexual intercourse with a child younger than 16 years is unlawful. This is about child protection first and foremost.
A very serious responsibility. And this leads us to the crucial topic of equity, stigma, and rights in STI care. The invisible barrier anchor.
Hugely important. All patients, regardless of their infection status, sexual orientation, gender identity, or background, have equal rights to respectful, non-discriminatory health care. Full stop.
But stigma is a huge problem, isn't it?
It really is. Negative public perceptions and social stigma surrounding STIs remain a major challenge worldwide.
How does it manifest?
It often leads to shame and fear, causing people to delay seeking testing or treatment. It can have significant mental health consequences, anxiety, depression, relationship difficulties. And it creates very real barriers to effective screening programs, open discussion about sexual health, treatment adherence, and crucial partner notification.
It's an invisible barrier to health.
Exactly, an invisible barrier that we, as clinicians, must actively confront.
So what's our role? What's the clinician's responsibility?
We have a professional responsibility and ethical duty to offer patient-centered, non-judgmental care. That means creating a safe, confidential space where patients feel comfortable discussing sensitive issues. It means using neutral language, protecting confidentiality rigorously, and actively challenging the stereotypes and misinformation, both within ourselves and in society, that limit patients' opportunities or well-being.
It's about treating the whole person, not just the pathogen.
Precisely. Empathy, respect, and advocacy are just as important as the right antibiotic here.
And there you have it. Wow. We've covered a huge amount of ground. We've navigated the complex landscape of genital tract infections, from the body's natural defenses like that amazing acidic army, and recognizing common red flags through specific STIs like chlamydia's silent sneak and gonorrhea's agile adversary.
So non-STIs like the yeast beast of candidiasis and those critical storch infections in pregnancy.
We've also touched on diagnosis, management principles, the absolute necessity of prevention, and just now, the critical importance of compassionate, stigma-free care.
And hopefully you can see the interconnectedness of it all. Anatomy, microbiology, pathology, pharmacology, public health, ethics.
Yeah.
It all comes together in this field.
Absolutely. Your journey as a medical student will involve not just memorizing these facts, the bugs, the drugs, the stages, but truly understanding these connections and their real-world impact on individual patients and communities.
That's the goal.
So as we wrap up, here's a final provocative thought for you, our future clinicians. Beyond the antibiotics and the lab tests, beyond the clinical guidelines, how might we, as a medical community, truly dismantle the stigma surrounding genital tract infections?
How do we make it so that everyone feels safe, respected, and empowered, seeking the care they need and deserve?
Keep that question with you. Mull it over as you continue your deep dive into medicine. Thanks for joining us.